Good evening, everyone, and welcome back. Unexpectedly, I got delayed for the part 2 of our discussion. Some of you have participated in the part 1, so let me restart our full-scale grand test and discussion. On routine physical examination, a 28-year-old woman, please inform that your classmates that live class restarted. Yes. 28-year-old woman is found to have thyroid nodule. She denies any pain, hoarseness, hemoptysis, or local symptoms. Serum TSH is normal. What is the best next step in evaluation? We need to do a fine needle aspiration. Palpable thyroid nodules are common and they occur in about 5% of all adults. The fine needle plays a very important role in the differential diagnosis. If the TSH is normal, then fine needle aspirate can distinguish between cysts from benign lesions or neoplasms. And how about thyroid scan? Thyroid scan can show a hot nodule which is almost always benign. But the TSH is suppressed because of all that surrounding autonomously overactive thyroid tissue. The TSH levels will be low if it were to be a hot nodule. But thyroid scintigraphy by itself cannot be able to distinguish the malignancy in the palpable nodules. And can the thyroid cancer can happen in young individual? Very much. It can happen in a young asymptomatic patient. So on a routine physical examination, 28-year-old woman is found to have a thyroid nodule. So that is the reason the first thing that you need to do is fine needle aspirations of the thyroid to differentiate whether it is a benign cyst or a benign mass or a malignant lesion. So the first investigation would become the fine needle aspiration of the thyroid is what you need to remember. Good to see 9 online coming back. So afternoon we had 1 hour of discussion, and after that unexpectedly I have few guests to attend. So in the home being Sunday, so I took little late to rejoin the class. Sorry for that. So now 32-year-old male presents with gynecomastia and infertility. Small firm testis, unicoid features, scant axillary and pubic hair. What is true about this person? Most likely, he is a case of Klinefelter syndrome. Hence, the karyotype is 47XXY. So, infertility, gynecomastia, tall stature is consistent with Klinefelter syndrome. And all that abnormal gonadal development, it is all because of the hyalinized testis, which lead to a low testosterone levels, is what you need to remember. But the pituitary is still intact. The moment testosterone, because of the hyalinized testis, testosterone when it goes low, then the inhibition on the production of the LH will be gone. So that makes the LH, FSH levels to be high, testosterone levels to be low in a patient who is having Klinefelter syndrome is what you need to remember. A 56-year-old man with a history of alcohol, tobacco abuse has complained of difficulty to swallow solid foods for the past 2 months. Recently, swallowing even fluids also became a problem. He noted black tarry stools on occasion, and the patient lost 5 kilos. What is the correct statement about this person? So you should remember, if you do barium contrast esophagogram, you will be able to establish a diagnosis. First of all, 56-year-old, tobacco abuse, loss of weight, you should always consider possibility of esophageal carcinoma. How will be dysphagia in esophageal carcinoma? It will be progressive. First for the solids, then for the liquids. Similarly, blood in the stool, history of weight loss. There are other evidences that are pointing towards esophageal carcinoma in this given case. Alcohol use and cigarette smoking, they are the risk factors. And prognosis is not good in this patient. Difficulty in swallowing is all because of the esophageal narrowing. That means this is an incurable form of esophageal carcinoma. A barium contrast can be able to demonstrate the presence of this esophageal carcinoma with marked narrowing and an irregular ragged mucosal pattern is what you have to remember. Now, 32-year-old alcoholic patient, the electrolytes show calcium 6.9, albumin 3.5, magnesium 0.6, phosphorus 2.0. What is the most likely cause of his hypokalemia in this alcoholic individual? So, there is a magnesium of only 0.6. That means there is also hypomagnesemia. So, hypomagnesemia decreases the end organ response for the action of the parathyroid hormone. Virtually, it will create a situation which is like hypoparathyroidism, and that lead to development of hypokalemia. So the major effect of hypomagnesemia on the parathyroid is a decreased end organ response. If the parathormone is not functioning, then 1-alpha hydroxylase in the kidney will not be available in a functional form. So that makes 125 dihydroxy vitamin D production also get affected. So that is the main reason for hypokalemia in this given scenario. A 38-year-old female who is recovering from mycoplasma pneumonia with increasing weakness. Her hemoglobin is 9 and her MCV, mean corpuscular volume, is 114. What is the best test to determine whether the patient has hemolytic anemia? A very important question. So you should remember, whenever hemolysis is there, the bone marrow is intact, right? So what is happening in hemolysis? RBC is leaving the bone marrow and it is getting destroyed peripherally. So when the RBC is getting destroyed peripherally, bone marrow is trying to compensate by increasing the reticulocyte production. So that is the reason brisk reticulocytosis is a very important indication of the presence of hemolytic anemia, is what you have to basically remember. A 69-year-old man with painless hematuria and a 52-year history of tobacco use. Now he presents with fever, chills, dysuria. Rectal examination, prostate is small, non-nodular, non-tender. Urine analysis is showing 120 RBCs per HPF. And the WBC and protein are not there. 3 months previously, the patient had an abdominal ultrasound for right upper quadrant pain and both kidneys were normal. So, what is the diagnosis in this case of painless hematuria in a person who has got a smoking history? And how do you want to proceed? Unexplained gross hematuria always require evaluation. Patients who have gross hematuria with a clear-cut urinary tract infection, they are usually treated because UTI lead to hematuria and followed with a repeat urine analysis until RBCs are cleared. But this patient has no symptoms of UTI, prostatitis, renal stones. They also can lead to gross hematuria. But in this, the evaluation is not suggestive of that. So, there is a possibility of bladder carcinoma. Especially 52 years, he finished his golden jubilee with cigarette packet. He has a great likelihood of developing bladder carcinoma. So it needs to be evaluated with cystoscopy and retrograde pyelography is what you have to emphatically remember. A 42-year-old previously healthy woman complains of severe excruciating headache and then has a transient loss of vision, loss of consciousness. There is no focal neurological finding. What is the best next test that you want to use to evaluate? Now, if you look at all the NEET PG 2020 exam pattern this year, 80% are all clinical based, image based, clinical vignette based, all USMLE exam styled questions. Only 10 to 20% are single liners. So, the most important thing is now the challenge is not just by hearting the concepts, but to start applying them in the clinical situation, clinical scenario, just like USMLE. So even Indian students are also made to take the exam like USMLE. Very good to find Himasagar. Excellent, doctor. Keep punching the answers. Keep punching. See, if you are punching, you are actively involved and that makes the whole learning exciting, doctor. So, CD scan without contrast. Excellent. Pavan Verma, very good to see. Non-contrast CT, very important. A 44-year-old Factory worker develops increasing weakness in his legs. Co-workers have noted episodes of transient confusion. The patient has bilateral foot drop, atrophy, wrist weakness. His CBP shows a hemoglobin of 7.6. Now, you should remember, there is a weakness, there is a motor neuropathy. Confusion, encephalopathy, bilateral foot drop. It could be neuropathy, also wrist weakness, right? And anemia. So what are you seeing here? Basophilic stippling. Keep punching the answers. Good to see Santosh Kumar, Pavan Verma, Himasagar, Ritesh, and many more who are all online. So what you are seeing here is stippling. Basophilic stippling is what you are typically seeing, which is classical feature of lead poisoning. So the nucleated RBCs contain basophilic stippling of the cytoplasm, which suggests toxic injury to the bone marrow, as in the case of the lead poisoning. Lead poisoning is what you have to appreciate. He is also having peripheral neuropathy with primary motor involvement. It may look like, what is the close differential diagnosis for lead poisoning? Motor neuron disease. But in motor neuron disease, what do you get? LMN features in the lower limb, upper limb. UMN features in the lower limb. So, upper motor neuron signs like hyperreflexia that you see in motor neuron disease are not seen in lead poisoning, because in lead poisoning all paralysis is because of peripheral neuropathy. Peripheral nerves lesion is called LMN. Androhorn cells, peripheral nerves, it's called LMN. So typically that is what you see in case of lead poisoning. And the cognitive changes that you see with lead encephalopathy, they are not seen in motor neuron disease, is what you have to appreciate. Very good to see Kasoju staphydoler. A 35-year-old male develops skin rash, pruritus, mild wheezing about 20 minutes after a intravenous pyelogram is being performed for the evaluation of the renal stone symptoms. So what is the best approach to the diagnosis? So skin rash, pruritus, mild wheezing after IV pyelogram. That itself shows that there is a radio contrast media sensitivity based on the history. So what are the signs and symptoms of the radio contrast media sensitivity, doctor? Tachycardia, wheezing, urticaria, facial edema, bradycardia, hypertension is what you have to remember. A 78-year-old woman with mild renal insufficiency complains of the pain in the right knee. There is no redness or swelling. That means it is not inflammatory arthritis. There is a very minimal joint effusion. ESR and WBC count are normal. And the pain is interfering with her day-to-day activities and relieved by rest. So, this is how you see classically that joint space narrowing and osteophytes are the classical features of osteoarthritis, is what you need to remember. So, mainly you need to give acetaminophen as a painkiller. So, you need to give physical therapy, symptomatic treatment with acetaminophen. Especially elderly people, acetaminophen is known to have a very good safety profile, is what you have to appreciate. And how about intra-articular steroids. Typically for large effusions in joints which are unresponsive to the first line treatment, you will be giving intra-articular steroids. Arthroplasty is also highly effective in treating osteoarthritis of a single joint, and it is not contraindicated in the elderly is what you have to remember. Now, doctor, which is a physiological parameter that does not change with the age as you keep aging, which will not change? Hematocrit does not change with the age. Very important. So, hematocrit does not vary with the age, and elderly patients with anemia, they require workup to define the disease process. The lung elasticity decreases with the age, and that is the reason there is an age-related normal decline of FEV1. Creatinine clearance decreases with the age, though the serum creatinine does not. And so that is all the quick story. Changes with aging, one of the favorite area. A recent outbreak of severe diarrhea is investigated. Adolescents developed bloody diarrhea, and one remains hospitalized with acute renal failure. And why such a group developed diarrhea? Because they all ate something in the restaurant. So which eating what will lead to this? It is called hamburger's disease. Hamburger. So E. coli O157H7. It will lead to a spectrum of clinical illness, that is mild diarrhea, hemorrhagic colitis with bloody diarrhea, acute renal failure, hemolytic uremic syndrome. So typically it happens by consumption of contaminated beef, in particular grounded beef, ingestion of raw milk, and a contamination via fecal-oral route, any of them. Now, 64-year-old man had entered myocardial infarction 3 months ago. He is on antiplatelet agent. He is on ACE inhibitor. ACE inhibitor, antiplatelet, what else will be prescribed for secondary prevention of MI, which is known to have a long-term good impact in the mortality morbidity. Always when the patient leaves home, don't forget, beta blocker is most important for the secondary prevention of the MI is what you need to remember. Beta blockers lower the risk of the MI reinfarction, whereas calcium channel blockers in fact may increase the risk of MI is what you should remember. Alpha blockers can be associated with an increased risk of CHF. ACE inhibitors are beneficial in this setting, and that's the reason they should be continued. And long-term use of NSAIDs, especially naproxen, is known to increase the risk of the MI. A 46-year-old male is persuaded by his wife to come for a general checkup. He tells you, doctor, this guy drinks, please talk to him. She'll be, because a physician is like a tribe leader. He's like a tribe leader. So therefore you should ask cage questions as a initial screen. So what are the cage cushions. You have to use an eye opener, early morning alcoholic beverage. So, cage screening tool for alcoholism consists of asking about alcohol related trouble, cutting down, being annoyed by criticisms. Do you have a guilt that you are drinking? And use of an eye opener, that is alcohol consumption upon arising. So these are the things which will act like a C for cutting down, A being annoyed, G for guilt, and E is eye opener. These things, these questions and the answers to that will act like a tool for screening the alcoholism. What is that called? Cage screening. Cage screening. During the neurological examination, you ask a patient to stand with both the arms fully extended and parallel to the ground and his eyes closed for 10 seconds. What is this test called? You ask the person to stand with both the arms fully extended and parallel to the ground and his eyes closed for 10 seconds. That is called pronator drift. So, pronator drift is used mainly to determine whether there is an upper extremity weakness. So, how do you do the pronator drift? The individual is asked to stand with both the arms fully extended parallel to the floor while closing his or her eyes. If the arms flex at the elbows or fingers, or there is a pronation of the forearm, that is considered to be a positive test, which is basically checking the motor weakness, and pyramidal weakness is what you need to remember. Alcohol effect on neurotransmitters in the brain. How does alcohol act on the neurotransmitters? It increases the GABA. GABA activity is what you need to remember. So what are all the drugs that act on the GABA system, doctor? Benzodiazepines, non-benzodiazepine, aids like zolpidem, anticonvulsants and muscle relaxants. They all act on the GABA system basically. Which is the hormone which is produced in the anterior pituitary, except oxytocin is not produced, vasopressin, oxytocin, positive pituitary. Growth hormone, ACTH, prolactin, they are all produced from the anterior pituitary. With regard to the primary immunodeficiency disorders, what is accept about it? Typically, infections of the upper and lower respiratory tract such as antibody response. Recurrent infections with candida, they indicate an impaired T-cell immunity. And most of these primary immunodeficiency disorders, they're all genetic with Mendelian inheritance is what you have to remember. And even innate immunity is also involved in the primary immunodeficiency. So I leave all the literature for you, doctor, in the onlinemmbbs.com video library. You have our full-scale grant test. Below that you have the videos. After we finish discussion, they get uploaded. And even this PowerPoint get uploaded so that you get a complete opportunity to do the self-driven revision also after this class is over, right? So, which is nearly twice as common in patients with diffuse cutaneous systemic sclerosis compared to limited cutaneous systemic sclerosis. Pulmonary fibrosis is more common in diffuse systemic sclerosis, is what you have to appreciate. Most patients with the systemic sclerosis can be classified either into limited or diffuse. And pulmonary fibrosis is a classical feature of the diffuse systemic sclerosis. Short bowel syndrome, for any reason, if you happen to do the resection of the bowel, that lead to short bowel syndrome. What does it lead to? It lead to renal calcium oxalate caliculi, very important. Gastric acid hypersecretion and cholesterol gallstone. These are the complications of short bowel syndrome. So, where do you first get short bowel syndrome? Whenever there is any mesenteric vascular disease, primary mucosal or submucosal disease, operation on a pre-existing small bowel disease like trauma, and multiple factors contribute to diarrhea and steatorrhea in short bowel syndrome, like gastric acid hyperproduction, increased bile acids in the colon, because if small bowel is not there, reabsorption, enterohepatic reabsorption does not happen. That makes increased bile acids remain in the gut, which enter into the large bowel, and that lead to development of diarrhea. Similarly, lactose intolerance because of the increased gastric acid secretion. These are all the issues with small bowel disease. Similarly, there is an increased oxalate absorption by the large intestine. If the small bowel is not there, there is an increased absorption of the oxalate in the large intestine that lead to hyperoxaluria. But why oxalate become excessively absorbed? Why? If there is a short bowel resection, if you do a short bowel resection, there are increased fatty acids entering into the colon. These fatty acids bind with calcium. So calcium is no more available to bind with oxalic acid. So that makes oxalic acid more free, that is unbound. And that unbound oxalic acid in the large intestine become more and more absorbed, and that excretes into the glomerulus, and that lead to development of hyperoxaluria and the stones, oxalate stones. That's the point you need to appreciate. Now, after a careful history, you diagnose that a 28-year-old woman with irritable bowel syndrome. What other condition would you reasonably find in this patient? Irritable bowel syndrome is like a psychosomatic manifestation, a conflict in the mind presenting itself with physical symptoms. So, associated psychiatric diagnosis in about 80% of patients with irritable bowel syndrome have a abnormal psychiatric features. They are hypersensitive to colonic stimuli. That's a point you need to appreciate. Even there is an association between history of sexual abuse and irritable bowel disease. A 32-year-old woman with chronic kidney disease is undergoing hemodialysis. She is found to be hypotensive. She gone into hypotension during the hemodialysis. What is the potential mechanism for the hypotension during hemodialysis is a very important question. The antihypertensive agents that you use, excessive ultrafiltration, impaired autonomic responses, they're all the important mechanisms for the hypotension during hemodialysis. In fact, the most common complication of hemodialysis is hypotension. What is the most common type of kidney stone? Any day, calcium is most common. Most common. 42-year-old woman is present with status asthmaticus. She rapidly deteriorates and dies. Then what are the pathological changes that you see in a case of status asthma? There is an infiltration of airway mucosa with eosinophils and activated T lymphocytes. There is an occlusion of the airway lumen by the mucus plugs. There is a thickening of the basement membrane of the airways with subepithelial collagen deposition. They are all the features that you see with the bronchial asthma in the pathology. Gopal is a 16-month-old boy. Still he did not say the first word. He does not babble much. His mother believes he does not hear well because he does not startle whenever a door slams, or he does not show any response to his name. His development is otherwise normal. Which test you want to do to find the Gopal's hearing? Come on, who is going to give me the correct answer? Should your answer, doctor? Who is going to give me the correct answer? Which test is best to assess the Gopal's hearing? Punch your answers, doctor. This question is for sale. Come on. So, ideally we should make these sessions become bilaterally interactive, both the sides. But unfortunately what happens is the time is a constraint. Please punch your answers, doctor. I want you to be awake, arise, and be very sure. Good. Ritesh says maybe C. Kasoju is saying distraction hearing test. Any other answers? Shoot. So, visual reinforcement audiometry is the one which you need to basically do. Basically, the test requires an assistant to play with the child and keep his attention. Behind a soundproof window, another assistant will play sounds through a loudspeaker at particular frequency. When the child turns around to the noise, a glass-fronted box with a previously dark toy inside lights up a visual reinforcement to reward the child for turning. That's called visual reinforcement audiometry, is considered to be the best test in this given clinical scenario. At what age would you expect the clinical features of spastic bilateral cerebral palsy to become evident? Typically in the 1 year, 0 to 12 months. Cerebral palsy often presents 0 to 12 months when acquisition of motor skills occurs very rapidly. Kiran, aged 8 months, presents with severe dehydration. He weighs 8 kgs. He needs a bolus of normal saline to treat his shock. What is the volume of that? That would be 160 ml. 160 ml. So a bolus of 20 ml per kg, maximum 1 liter. So this is typically given over 20 minutes in a child who has got a moderate dehydration as fast as possible. If it is severe dehydration. So he is 8 kgs. So 20 ml per kg means 8 into 20 is 160 ml has to be administered. The baby is at increased risk of which of the following health problems because of the mother's smoking habit during pregnancy. Maternal smoking can lead to a benign growth restriction. It can lead to. It is also associated with risk of stillbirths and miscarriages. Lowest risk of cardiovascular disease in the newborns, which has the lowest risk of cardiovascular disease. 3.9 kgs baby has the lowest risk out of all this. Too large and too small a baby also has a risk. That's called Barker's hypothesis. What is the first step in the management of upper airway obstruction in a patient who is having anaphylactic reaction? You need to assess the airway and give him the high flow oxygen is considered to be the first step. A patient is having normal anion gap metabolic acidosis and urinary gap is positive, not negative, and urine pH is more than 5.5. Hypokalemia and lack of, and you are unable to acidify the urine normally. So that all points towards renal tubular acidosis. Which type, doctor? Distal renal tubular acidosis. It takes a little long time to explain this question actually. So I urge you all, doctor, please go back to onlinembbs.com video library. In that, renal tubular acidosis is the most well discussed topic. You can do the revision. In that we discussed type 1, type 2, type 3 RTA, urinary anion gap. If the urinary anion gap is negative, the cause is the gut. But here it is positive, right? So, if the gut is the cause of the normal anion gap metabolic acidosis, then urinary anion gap become negative value is what you have to remember. What is the most common type of congenital heart disease? Overall, it is the ventricular septal defect which is most common. Durga is a 14-year-old girl. Very good to see Shivam Panchal on this wonderful evening. Welcome, welcome. So, I hope you all guys are getting the YouTube notification whenever we are starting the class. Am I right? So, that is one thing that will be calling you. That's the reason always click on that notification bell sign so that you get a notification immediately as we start the session. Second thing, be part of our Telegram group and our WhatsApp study group. If you are not yet part of our group, please call 9000-868-356. So by being part of our Telegram and WhatsApp group, you get an opportunity to be notified whenever our session begins, right? Today it is very easy for teacher to sit anywhere and can be able to spend with the students for hours together discussing the subject interactively. You also at your comfort zone, teacher also at comfort zone. That is a great opportunity in the modern internet era, right? Now, 14-year-old girl has always been quiet and hardworking. She is very thin, losing weight. Even though she is interested in food, she enjoys baking cakes for her classmates. Always keen to go to supermarket for her mother. But Durga herself denies that there is a problem with her weight. She denies that she has been vomiting every time she is having food. Her parents are both extremely worried about her weight loss and a poor appetite. So what is your diagnosis, doctor? Anorexia nervosa. Thank you, Shivam, for a compliment. So, a newborn baby is diagnosed with a metabolic condition at 10 days of age. After she presented with vomiting, jaundice, hepatomegaly, liver failure, she is put on lactose-free, galactose-free diet. So what is the most likely enzyme deficiency may be responsible for vomiting, jaundice, hepatomegaly, liver failure in this newborn baby? It is GALT, galactose 1-phosphate uridyl transferase enzyme, which is typically deficient in the patients who are having galactosemia. What is a complication of a jejunal-ileal bypass? If you happen to do jejunal-ileal bypass, you are resecting a significant part of the small intestine. That makes fatty acid absorption to get affected. That makes increased fatty acids to enter into large bowel. The fatty acids in large bowel will be binding with calcium. So calcium is no more available to bind with oxalate, and that lead to hyperoxaluria and development of oxalate stones is what you need to remember. 82-year-old man with a history of coronary artery disease. Asymptomatic reducible inguinal hernia. Request for an elective hernia repair. Now, what is a valid reason to delay the proposed surgery whenever a person has got multifactorial risk factors? If there is a jugular venous distension, which is a sign of right heart failure, it is a reason to postpone the surgery. So, perioperative myocardial infarction risk factors are identified by Goldman. The highest risk factor is associated with recent myocardial infarction. The more recent the event, the higher is the risk up to 6 months, is what you have to emphatically remember. A 78-year-old thin cachetic woman undergoes a tracheostomy for failure to wean from a ventilator. 1 week later, she develops a significant bleeding from the tracheostomy. What is the initial step of management for this given problem? You attempt to re-intubate the patient with the endotracheal tube is considered to be the management of choice in this given scenario. So the patient had a sentinel bleed which happens from the tracheoinnominate artery fistula, which carries more than 50% mortality rate. So if the bleeding is ceased, then immediate fiber optic exploration in the operating room is indicated in her given case. A 58-year-old woman requires abdominoperineal resection for rectal cancer. She has a history of stable angina. So what is the most likely predictor of a cardiac event during a non-cardiac surgery? And hence you need to more investigate the cardiac status. Any unstable angina. You should do a coronary angiogram. If required, you need to do stenting or a revascularization. Then only you need to post them for the non-cardiac surgery. Commonly patients with knee transplant surgery, prostate surgery, etc., they'll be sent to cardiologists for a cardiac risk evaluation. So, if on the history it is being found that the patient has got unstable angina, you need to much more thoroughly investigate the patient and revascularize the coronary vasculature. Then only you need to post for the non-cardiac surgery. Very important dicta. A 42-year-old man who was in the house fire is transferred to your burn unit. He has complete burnt nose hairs, facial burns. Direct laryngoscopy is performed in an emergency room, shows pharyngeal edema, mucosal sloughing. And good to see Deepak Jaiswal and many more who are all online. Doctor, I want to ask you an honest opinion. Please help me. We tried different timings. Sometimes early morning, 5 to 7 used to be the class. Evening 6 to 8. Evening 6 p.m. to 8 p.m. is another time where everyday class used to be live broadcasted. 8 to 10 or 10 to 12. Between them, please vote. Which is the best time? I am giving you 4 choices. 5 a.m. to 7 a.m. or 6 p.m. to 8 p.m. or 8 p.m. to 10 p.m. daily class I am talking about, or 10 p.m. to 12 p.m. or 5 p.m. to 7 p.m. What is the best time you feel is comfortable for a good number of you? Our Shivam Panchal is saying 6 p.m. is best. Kasoju is saying 8 to 10. Okay. How about others? Please punch. Deepak says 10 to 12. I am nobody says 10 to 12. Okay. Ritesh Raja says 6 to 8. Please tell what is the most comfortable time for a daily live online class without a break. So every day we will discuss 50 USMLE style clinical questions, 50 questions. Because NEET PG also has become like USMLE now. Critical based questions, image based questions, VNet, similarly case study based questions, etc. etc. Kasoju says daily means 10 to 12. 10 to 12 I got Peace Mind, Pavan, Kasoju, I am nobody, Deepak Jaiswal. A good number of you are favoring 10 to 12. Even Nishala also is proposing 10 to 12. So you are all nocturnal carnivoral creatures killing the all NEET PG material for the forthcoming exam. Huh? Very good. Sure. So all of you be part of you be part of the Telegram and WhatsApp study group. If you are not yet part of it, please call 9000-868-356 and request our 24x7 helpline to include you into the Telegram and WhatsApp group. Of course, Pavan Verma, everyone are all on WhatsApp. I mean, on our Telegram group, very actively, every 5 minutes, one question we're all working on. Yeah, Shivam says 10 to 12, that is the majority. Oh, good. That's a good feedback, doctor. Definitely. So, 50 questions of USMLE style, which we are going to discuss every day. We will post it in the Telegram group beforehand. You try to answer them. Yeah. Kasoju says 10 to 12. Lock kijiye. Computer Mahoday. Very good. Good, good. So, and next Sunday onwards, I am delivering a day-long session, morning 10 a.m. to 5 p.m. doctor, 5 p.m. There are a lot of final MBBS students, There are 10 medical colleges in Hyderabad. Almost any given point of time, we have about 2,000 undergraduate medical students who are in final year. Still, the present final year batch is who entered into final year. They are not the victims of the next exam. But yes, next year final year students are going to be take a major hit with the next coming up in 2022. So they all requested, please do a quick revision of the final year subjects. Even entrance going students also. So morning 10 a.m. to 5 p.m. marathon session, live online, face-to-face class in Hyderabad, in Nampally, that also become broadcasted live. So please take opportunity to participate and also tell your juniors. And four Sundays I finish medicine. Then after that, another 4 Sundays I finish surgery. Another 4 Sundays I'll be finishing gynecology and obstetrics. So next 12 Sundays, that is next 3 months in a marathon on every Sunday. So please tell your friends also to join. It is a free live online broadcasted session on the YouTube. Only thing is we remove the video after the session is over and archive it into onlinembbs.com video library. And we want you to subscribe. Pay for the subscription and enjoy the revision of all these archived videos. So, nobody is saying it is really inspiring. Maybe you are the only teacher I have seen who is asking which time is comfortable to students. Thanks goes to YouTube, because simply on a small laptop, watching into my camera, I am able to reach out to all of you at the comfort of the home. So today modern learning is all about how easy, how comfortable we are all able to interactively study together every day, which is the buzzword. Right, doctor? So it's a consistency. Every day study is most important. So what I thought is 50 USMLE style questions. 50 USMLE style questions every day. Because ultimate exam is also like more or less like USMLE. So you get the question paper in the Telegram and WhatsApp group beforehand. So doctor, 42-year-old man. So what do you want to do in this given case? Because there is an upper airway burns, it becomes an indication for endotracheal intubation. With regard to healing process, which cell types are the first infiltrating cells to enter into the wound site, peaking at 24 to 48 hours? It is the neutrophils which make an entry. So wound healing is a sequence of inflammation, proliferation and remodeling is what you have to appreciate. So there's a rapid influx of the neutrophils followed in about 2 days by an influx of the mononuclear cells. A 64-year-old diabetic man undergoes incision and drainage of an infected boil on his back. The wound is left open and packed daily. Week by week, the wound grows smaller and eventually heals. What do you like to call this as? This is called healing by secondary intention. There are 3 types of wound closures. Primary intention, secondary intention, tertiary intention. In primary intention, Closure of the edges of the wound are brought together and they are sealed immediately with a simple suturing, skin graft placement or a flap at the end of surgical procedure. Secondary intention, closure, it involves leaving the wound open but without active intent to seal the wound. The wound heals by re-epithelialization, which leads to contraction of the wound if it is secondary intention, is what you have to remember. And a 32-year-old woman follows an automobile accident. She is acutely dyspneic, respiratory rate is 60 breaths per minute. And what you can see here, no bronchovascular markings. There are no bronchovascular markings. So this is all the area where you are able to see no bronchovascular markings. That means it is all the air which is filling this pleural cavity that has got a tamponating effect on the heart and it is pushing it, and you are able to see the lung completely condensed. This is a tension pneumothorax. Tension pneumothorax. So this is the heart shadow. This is the lung shadow which is being pushed, and this is all the tension pneumothorax. So decompress this pleural space. It is not right, it is left the pleural space. That is considered to be the management of choice. Now, 74-year-old man with several fractures, a ruptured spleen after falling 20 feet. What will occur in response to this injury? Acute phase reactant production increases. The liver production of acute phase reactants will increase dramatically in this scenario, is what you need to remember. Any injury or sepsis, it will lead to accelerated protein breakdown. Wow, Rituraj, very nice to know. Sir, because of this class, I got 12,952. Excellent, doctor, excellent. So, Ritu, what is a branch you are dreaming for, looking for, and what it looks like with the rank with 12,952? Is the counseling over, doctor? Are you still having anesthesia? Very good. Excellent, Ritu. I am so proud of you. Basically, you guys will get seat because of you. Your hard work, mehnat. Our job is, we have no other job. We are jobless MD General Medicine. So that is the reason. It's a fortunate opportunity you are all giving me to study every day, be a student every day, and enjoy your companionship. Thanks for coming for this session every day. So, injury and sepsis, they lead to increased protein breakdown, increased urinary nitrogen loss, increased peripheral release of amino acids. There is a negative nitrogen balance, and amino acids like alanine are released by the muscle, transported to the liver, and incorporated into acute phase protein formation. So what are the acute phase proteins, doctor? Fibrinogen, complement, haptoglobin, ferritin, they're all acute phase proteins. A 23-year-old man arrives after a motor vehicle collision. There is an unstable pelvis. There is blood at the urethral meatus. How do you identify urethral injury? Retrograde ureterogram is basically done to identify the urethral injury. A Foley catheter is inserted into distal urethra and minimally inflated. After that, you instill a 30 ml of water-soluble contrast and a plain radiograph is being obtained. That's called retrograde urethrogram, which is essential for the diagnosis of urethral injury, unless there is a negative retrograde urethrogram, you should not attempt to insert the bladder catheter, is what you need to remember. And a stress cystogram is useful to diagnose a bladder injury. That's the point you need to appreciate. A 54-year-old woman in renal failure is listed as a transplant candidate. In order to know the propriety of transplant, which combination represents how a cross-match is being performed? Donor lymphocytes versus recipient serum and complement. You look for the mismatch reaction to become visible. What is an indication to do a heart-lung transplant? Heart-lung transplant. Idiopathic dilated cardiomyopathy with a long-standing secondary pulmonary hypertension. Unless you do heart-lung transplant, the patient's chance of survival are gone. So, many cases of end-stage lung disease have been appropriately treated with lung transplantation. Primary pulmonary fibrosis, if you do single lung transplant, they will survive. For patients with primary pulmonary hypertension, unloading of the right ventricle with a single lung transplantation also has been adequate. Cystic fibrosis patients do well after lung transplantation, but you require to do double lung transplant in them. But whenever there is a dilated cardiomyopathy, along with pulmonary hypertension, secondary pulmonary hypertension, then that is an indication for combined heart-lung transplantation is what you need to remember. What is the primary toxicity of doxorubicin? Doxorubicin lead to pulmonary fibrosis. So, quite often in the non-seminomatous testicular tumors with an elevated levels of the beta subunit of the HCG alpha fetoprotein LDH, they are all indicators of the tumor activity and recurrence. And whenever you are using chemotherapy, you should know the important adverse effects. So, vincristine lead to CNS toxicity, vinblastine lead to bone marrow toxicity. Adriamycin mainly lead to cardiomyopathy actually, cardiomyopathy. And 15-year-old, so the answer should be corrected, doctor. Cardiomyopathy is the primary toxicity. Answer should be A. Now, bleomycin-like drugs lead to development of pulmonary fibrosis. A 15-year-old, otherwise healthy female high school student noticed to have galactorrhea. A pregnancy test is negative. What is frequently associated physical finding? Bitemporal hemianopsia. Bitemporal hemianopsia, because it's a case of prolactinoma. Prolactinoma lead to compression of the optic chiasma leading to bitemporal hemianopsia. A 38-year-old woman presents with hypertension, generalized weakness, polyuria, and her electrolyte panel is significant for hypokalemia. Hypertension, generalized weakness, and polyuria, and hypokalemia. So, how do you want to evaluate? You need to look for plasma renin activity and plasma aldosterone concentration in this given case. Because she has hypertension. Hypertension can be because of hyperaldosteronism, which can be primary, which can be secondary. And if it is secondary, it's quite often because of a renal artery stenosis leading to high renin, leading to high angiotensin and aldosterone that lead to development of hypertension. So whenever hyperaldosteronism is there, you should demonstrate elevated plasma aldosterone concentration with suppressed plasma renin activity. So PAC to PAR ratio. That is suggestive. Suppose if it is not secondary hyperaldosteronism, but it is because of a suprarenal gland, adrenal adenoma led to hyperaldosteronism. Then there will be high aldosterone produced by the adenoma, but renin will be typically low. So low renin, high aldosterone combination. So if you do plasma aldosterone by plasma renin activity, if the ratio is 25 or 30:1, that means high aldosterone is there with a low plasma renin, which is suggestive of primary hyperaldosteronism. But first of all, when do you suspect hyperaldosteronism? Any hypertensive who presents with hypokalemia, you suspect presence of hyperaldosteronism. What is the most common serious complication of an end colostomy? So, any parastomal hernia is a serious complication of a end colostomy. The most frequent serious complication of end colostomies are all parastomal herniation, which often occur when the stoma is placed lateral to rather than through the rectus muscle. That's what you need to remember. And a 54-year-old man presents to the emergency room with a 6-hour history of excruciating abdominal pain and distension. And what is the most appropriate next diagnostic test that you want to do? So a markedly, actually that X-ray is missing here, a markedly distended colon on X-ray. It can be due to tumor, foreign body or colitis. And sigmoid volvulus may be ruled out by proctosigmoidoscopy, which is preferable to barium enema, because a sigmoid volvulus can be treated by a rectal tube decompression via that sigmoidoscope that you pass. Actually, that X-ray must be there. Somehow it was missing. Yeah. A 38-year-old woman presents with abdominal pain and jaundice. Subsequent ERCP shows congenital cystic abnormality in the biliary system. So, what is the most important? It's a choledochal cyst. Choledochal means bile duct developed a cystic dilatation. So, what do you want to do? You need to do cholecystectomy with resection of the extrahepatic biliary tract, and Roux-en-Y hepaticojejunostomy is what you need to perform. So whenever cystic dilatation of extrahepatic biliary duct congenitally are there, then they carry high morbidity, mortality if you don't manage them. And typically the resection of the cyst with cholecystectomy and Roux-en-Y hepatic directly liver to jejunum is being connected. No more bile duct from the liver going into duodenum, that going into jejunum, all that path is bypassed. That's what you need to remember. And malignant changes can occur frequently in the choledochal cyst. A 68-year-old man is seen because of facial swelling, cyanosis, especially when he bends forwards. There are a lot of dilated subcutaneous veins in the upper chest. His jugular vein is very prominent. So what is the most likely condition? So it is a superior vena cava syndrome, which is quite often a complication of the bronchogenic carcinoma. Pancreas tumors, apical squamous cell carcinomas can lead to development of superior vena cava syndrome is what you need to remember. A 56-year-old woman presents for the evaluation of a mid-diastolic murmur on 2D curve. You are able to see, what you are able to see? There is a mass in the left atrium. Left atrium. This is the classical presentation of cardiac myxoma, is what you need to remember. A 46-year-old man presents with a solitary lung lesion. At the time of the operation, patient is having a firm rubbery lesion in the periphery of the lung. You are able to see hair, teeth, dentin, everything inside this. So what is this most likely to be? Hamartoma. Hamartoma. When there is a cartilage, smooth muscle, etc., there is a hamartomatous tumor. Pulmonary hamartomas are the lesions in the pulmonary parenchyma. They appear as asymptomatic peripheral nodules, is what you have to understand. A 80-year-old man is found to have a asymptomatic pulsatile abdominal mass. An arteriogram is being shown. So what is it showing? Aortic aneurysm. So what is the important complication that can occur? It can undergo a rupture. It can undergo a rupture. This aortic aneurysm on arteriogram can undergo rupture. Any focal dilatation of the artery more than 1.5 times of its diameter is called aneurysm. And if the aneurysm diameter is close to 3 times the size of his normal aorta, then it can undergo rupture. That's the point you need to appreciate. A 60-year-old man is found to have 3 centimeter pulsatile mass in the right popliteal fossa. You are able to see? So this is one of the peripheral, very common peripheral arterial aneurysm, popliteal artery. What is the best management of this given case? You need to do surgery. Popliteal aneurysms are the most common peripheral arterial aneurysms that are bilateral in 53% of patients. Dr. Vikas has given a donation of 200 rupees to YouTube, not to me. Vikas, thanks for your appreciation, but YouTube don't pay us. So, please call 9000-868-356 and subscribe to our online mbbs.com video library. That would be a great use for the students, and also when you subscribe, when you pay and subscribe to our online mbbs.com video library and mock test series, that also helps us to make payment to our so many staff who work with us to run this organization. Online mbbs.com, we had been mentoring the students past 21 years almost. 2 lakh students. So, a good number of times, a good number of students, they join for free. Some people pay as small as $1,000. Even then we help them to get an access. Some students pay ₹1,00,000 also and buy the subscription. So it is all a question of doing a good work, opportunity to do good work. And ultimately, tomorrow, you also, when you become consultants, somebody can pay, somebody cannot pay, but ultimately, both of them are same when it comes to when it comes to your capability, opportunity to treat the humans. So that is the reason a lot of times what happens is when somebody gets admitted, we keep talking about who will pay, insurance pay, government insurance pay, private insurance pay, or patient's son is going to pay. So does it mean that someone can't pay is bound to die? No, there is a value for the human life. Money is an artificially created green currency, right, doctor? So that is the reason that's very important, even as clinicians, to be democratic, and at the same time, the one who can pay will pay. Those who cannot pay, you should find a way how you can manage to admit and manage the patient. That's most important. Now, doctor, a 39-year-old man presents to the emergency room with renal coli. His vital signs are normal and urine analysis shows microscopic hematuria. A radiograph shows 1.5 centimeters stone. What is the most appropriate? Very good. Pavan says, I paid 10,000 rupees, sir. Good. Thank you for that. And so do you think, Pavan, whatever you paid, did you get a value for the money? One of my friend, an orthopedic surgeon, he took his daughter, finished housemanship, she could not qualify. He took her to a coaching center in Hyderabad. They are charging, it seems, about 82,000 rupees. There is a crowd of about 500 students sitting there. And she ran away and came and said, 2 hours I felt sleepy. Somebody is talking and 12 hours to sit in a stretch is impossible for me. It's a torture. So, there are some commercial coaching centers that charge 80,000, 90,000, a lakh rupees also. But that is not right, right? So, what is important for you is everyday study for a couple of hours with a teacher who is also becomes a student with you every day. Be surrounded with a group of classmates, either on social media or in physical environment. And be sure what are the 953 topics that you need to master. Take every Sunday one full-scale grand test and check how good you are able to perform. And of course, we have an online video library of archived video content. It is once more like any other book. You feel sleepy beyond 1 hour, 2 hours. If it is mobile app, it is altogether miserable. It is a small screen where you need to look for. So, that is most important. To be in the game, every day, across the year is very important. Once more, what happens, doctor, when it becomes September, October, that time if you have to open and study, propofol is used in daycare surgery, propofol is used for intensive care unit sedation. What is the effect of it on seizure threshold? If you have to read it in September, October, tension build ho jata. From now only, keep a target. If you don't have that list of 953 topics, please call our helpline. They would be more than happy to give you the 953 topic list. So, master those topics. We already have 30-40 MCQs on each of this topic discussed, debated and made available in the online mbbs.com video library. You can always do the revision. Every day keep 10 topics, aaj khatam karunga. 10 topics today I am going to finish. Like that. And every day evening, join Dr. Murli Bharadwaj for a chai pe charcha or a post-dinner meet. A couple of hours for an interactive live discussion every day. That's all, doctor. That is the formula for winning and cracking any entrance by any student for that matter. Right? Now, extracorporeal lithotripsy is the treatment of this renal coli. So, if the renal stone size is 1.5 centimeters, extracorporeal shockwave lithotripsy has a great role. It is completely non-invasive and delivers the shockwave energy to the stone under fluoroscopic guidance. If the stone size is less than 1 centimeter, it can be managed with hydration and analgesics until the stone passes spontaneously. And one of the recent observations is alpha blockers, which are usually used in the treatment of men with bladder outlet obstruction, are being shown to potentiate the likelihood of stone expulsion for the small stones, is what you need to remember. Now, the left ureter is partially transected because there is a difficult operation in an unstable critically ill patient, and left ureter is partially transected. What is the most appropriate management of this injury, doctor? So, you have to place an external stent through the proximal ureteral stump with a delayed reconstruction later. So that is considered to be the management of the ureteral, if the ureter happened to get injured. A lot of times gynecologists, while doing hysterectomy, lead to injury to the ureter while they are trying to clamp the uterine artery. So that time, the management is external stent through the proximal ureteral stump, which got transected with delayed reconstruction. A 22-year-old medical student develops peripheral vision abnormality, and a CT scan of the brain is showing a pituitary adenoma. A calcified suprasellar lesion. Calcified suprasellar lesion, not pituitary adenoma. Suprasellar lesion, which is typically craniopharyngioma. So surgical resection is considered to be the management of choice. A 48-year-old man with a strong history of cigarette use and heavy alcohol biopsy shows squamous cell carcinoma, intraoral mass. Chest X-ray shows hyperinflated lungs. What do you do to do the staging? You need to do esophagoscopy. There is often a synchronous cancer in both aerodigestive tract. Both broncho and also esophagoscopy are recommended, is what you have to remember. Which is associated with a imperforate anus. Imperforate anus. Congenital heart disease. Congenital anorectal anomalies are frequently associated with heart disease, esophageal atresia, abnormality of the lumbosacral spine, double urinary collecting system with drooping water lily sign, it is called, hydronephrosis, and any communication between rectum and urinary tract and vagina or perineum. So that is a point you need to remember. Vacteral syndrome. What is Vacteral syndrome, doctor? Vertebral anomalies, anal atresia, cardiac defect with VSD, tracheoesophageal fistula, renal anomalies, and limb defect like radial dysplasia is what you have to remember. A 35-week term infant presents with cyanosis shortly after birth. His arterial oxygen saturation is only 30%. What is the most likely diagnosis? Always remember, what are the 4 T's that lead to cyanosis at birth? Cyanosis. Tetralogy of Fallot, tricuspid atresia, transposition of the great arteries, and total anomalous pulmonary venous circulation. They all lead to development of cyanosis at birth. A 52-year-old man was the restrained driver in motor vehicle collision. What is an important finding on chest X-ray that says that this man has developed a aortic injury of the aorta? The widening of the mediastinum more than 8 centimeters. More than 8 centimeters. Widening of the mediastinum more than 8 centimeters. Mediastinal widening is a sign of aortic injury. So that brings us to our 2.5 hours of long discussion, doctor. So thank you all for giving your wonderful Sunday. And depending upon a little flexibility of my timing, sometimes 6 to 8 p.m. or 10 to 12 p.m. Either of these two timings, I will try to conduct a class. Sometimes if I get late from the hospital, then I'll try to do it at 10 to 12. If I'm able to bail out myself a little early, I will make it 6 to 8 p.m. live broadcast. So please call 9000-868-356, our helpline number, and subscribe to onlinemmbbs.com video library, and also our Telegram group and WhatsApp group. Be part of it. You get about almost 150 questions every day, and participate in a live interactive session every day. Good night and enjoy. The night is young and it is Sunday, a great time to do many beautiful things other than NEET PG preparation. Thank you.